for giving me this opportunity to give this talk this afternoon. The title of the talk is Effect of COVID-19 on Normal and Diseased Liver. I have no disclosures related to this talk. February last year, 2020, just after this COVID-19 pandemic was declared by WHO, the APSL, the Asian Pacific Association for the Study of Liver, developed a COVID-19 task force, and the agenda was, how do we actually manage our liver disease patient or patients who would get liver disease related to COVID? And so this panel really produced the guidelines for hepatology and liver transplant providers in general, as well for physicians who were, treating COVID-19 patients. Let's start with some very basics, general considerations, like COVID-19 is caused by SARS-CoV-2, a positive single-stranded RNA virus. We all know that it belongs to the genus beta coronavirus, which includes SARS and MERS. The genome is 79% similar to SARS and 50% to MERS. We were all very familiar with, the MERS virus and the SARS previously, but we had no clue about this new virus, which was COVID-19, as it was found out in 2019. Binds to ACE2 receptor via receptor binding domain on the spike protein and spreads predominantly by respiratory droplets. We're all still learning about it, so hence title is that it's an emerging infectious disease. Presented initially mainly as viral pneumonia, respiratory bone illness, spreads easily from person to person. It's insidious and treacherous. Asymptomatic infected people can spread the disease. There is a high degree of morbidity and mortality compared to seasonal influenza. It has got devastating results sometime in a especially subset population, those who are elderly, and especially those with underlying heart disease, lung disease, diabetes, who are obese and have liver disease. As we are very familiar now with all the experiences that have accumulated since we started to learn about it, the proportion of disease increases with age. But at the same time, I think the important dictum should be that no age bar is immune from COVID-19. So the pediatrics, which were initially suggested that there is very less incidence of pediatric, but no more. The pediatric, as the waves become first wave, second, third, we are still learning that no age bar is immune. But yes, there is an agreement that the advancing age groups have more morbidity and mortality. So as it's rightly pointed out, the deaths as we extend in our years beyond 60, there is more mortality related to this disease. Liver involvement in patients is universal. All the liver enzymes get altered, especially when you are in ICU care and the p-values become more and more significant. Here are some of these pictures coming from unfortunate patients who could not make it, the patients through their autopsy studies. As you can see, there is massive portal vein dilatation, and there is a sclerotic portal vein wall. It becomes more and more thickened, followed by the CD34 staining, decorating endothelium of dilated and proliferating portal veins, and abnormal CD34 staining in the sinusoids. And it's all leading to diffuse thrombotic phenomena in liver intraparenchymal vessels. Sinusoidal involvement is characterized by intravascular fresh clots. That's what is happening. Subtotal thrombosis of an enormously dilated portal vessel. The portal vein subtotal recent thrombosis. So this thromboembolic phenomena associated with the SARS-CoV-19 really produces catastrophic results, even in patients who sometimes are doing good and suddenly they start to deteriorate. We have also coined the new term, which is called viral sepsis, which involves the respiratory failure phenomena, the metabolic acidosis, kidneys, liver, and cardiac injuries resulting from this phenomenon of viral sepsis. What about the spectrum of liver injury in COVID-19? Studies looking specifically for liver injury. The liver injury would be defined hepatocellular, ductular, or mixed, and the pattern of injury existed in almost, in this format, hepatocellular or mixed. On admission, for instance, there could be 50% or more patients with signs of liver injury, and during hospitalization, it extends due to a variety of reasons, as already said, the viral sepsis, etc. It further deteriorates. Liver injury, higher odds for severe COVID-19. So as the disease progressively gets worse, we have got more and more phenomena of liver injury with significant odds ratio and confidence interval. Let's not forget about the DILI phenomena in COVID-19, the DILI, drug-induced liver injury. Patients suffering from all kinds of, certain viral infections do produce problems of DILI, especially with HCV, HIV, and others. We all know that in these patients with COVID-19, they are on hosts of medications, the antipyretics, antivirals, antibiotics, antifungal, etc., etc. Fatty liver can sensitize liver to hepatotoxins such as acetaminophen. Link may exist between COVID-19 and liver steatosis. Of course, the recent postmortem studies have also shown microvesicular liver steatosis. So COVID-19 in patients with established liver diseases, are CLD patients more susceptible to COVID-19? Do they have severe COVID-19 if infected? Outcome of CLD cirrhosis after COVID-19, and care of uninfected CLD patients during COVID times. We also established, a group which studied the APCOLIS study on the APSL platform. Pre-existing liver disease is associated with poor outcome in patients with SARS-CoV-19. Now, we looked at that time, the data. This was reported last year, June 2020, and the conclusion was SARS-CoV-19 infection, SARS-CoV-2 infection causes significant liver injury in CLD patients, decompensating 1/5 of cirrhotics and worsening the clinical status of already decompensated. The CLD patients with diabetes and obesity are more vulnerable and should be closely monitored. So it may extend from a normal thing when you have got a patient who is unknown to have a liver disease. Unfortunately, I have seen and my colleagues have seen phenomena of acute liver injury and acute liver failure in such patients who were not previously known to have liver disease. And these are individual experiences, and collectively the data is coming out. There could be mild or moderate ALT and AST elevation. However, in chronic liver disease patients, the situation could be different, like ACLF and decompensation. Why are liver disease patients more at risk? Gut liver have second highest COVID-19 virus because of the enterocytes and cholangiocytes. It's not just the respiratory tract and the lungs. Our specialized field, the liver and the GI tract, have the second highest, in fact, the viral accumulation, because they have this receptors. Not known if compensated CLD HBV patients are more susceptible, but I have seen and my colleagues have seen that it is not universal. We are seeing patients who definitely decompensated. Advanced cirrhosis with HCC, AIH, post-liver transplant susceptible are immunocompromised and hence are more susceptible. Stable HBV and HCV COVID-19 patients without COVID-19 continue the treatment. COVID-19 positive continue on ongoing treatment, treat HBV reactivation, or if IL-6AB, the antibody, are you giving it, or the immunosuppressive therapy. These could happen. Be very, very vigilant. Initiate HBV and HCV routine treatment. HBV, CLD, and COVID-19, the initial data reported from, again, Wuhan, China, certainly confirmed this thing that cirrhotic patients certainly did worse with previous HBV infection, as you can see the p-values, and people have come across this phenomenon since then as well. What about the other entity, which is a global pandemic as well, which is the MAFLD, metabolic associated liver disease or fatty liver disease? So undiagnosed MAFLD and diabetes more susceptible. ACE2 expression has been shown to increase in liver damage, higher uptake of COVID-19, and MAFLD patients may have enhanced risk. So we set up an editorial published in Journal of College of Physicians and Surgeons, looking at all what we knew, in fact, regarding it. And every data that is coming out globally has emphasized that NFLD patients are more susceptible towards liver-related injury and morbidity and mortality in patients with COVID-19. So independent risk factors other than age, male, BMI, comorbidity, NAFLD carries additional risk factor with an odds ratio of 6.4. Higher risk of establishing worse outcome with NAFLD patients related to higher risk of disease progression, higher likelihood of abnormal liver function from admission to discharge, and longer viral shedding. Why NAFLD can lead to progressive COVID-19? Liver has the largest number of macrophages, the Puffer cells. There is increased pro-inflammatory cytokines, the TNF-alpha, impaired innate immunity with increase of pro-inflammatory M1 macrophages. This results in progression of COVID-19. Are HCC patients at risk for COVID-19? There is limited data. In general, cancer patients are most susceptible to infection. So let's again get into data coming out of China. 18% had a history of cancer and no HCC, higher than incidence of cancer in the overall Chinese population. 25% of cancer patients had history of chemo or surgery in the last 1 month, more admissions and worse outcome. Patients with cancer deteriorated more rapidly than those with without cancer. The median time to severe events was 13 days versus 43 days. The hazard ratio 3.56 after adjusting for age. So I don't have exact data on HCC, but extrapolating data from cancer patients itself, certainly the news isn't very good as is expected. So the dictum coming out of our panel was continue monitoring on and off therapy for HCC, continue surveillance in those at risk for HCC close to schedule. Delay of 2 months may be reasonable, but not now. This was last year in 2020. Discuss risks and benefits of delaying surveillance. Again, one has to be cognizant of the fact that disease is deadly and why delay it. Postponing of elective surgery, TACE, RT, or immunotherapy for uninfected stable HCC may be considered. Again, it was last year's dictum, and certainly as things have improved since then, we can be, continue to do as we used to do. ACLF, the acute chronic liver failure, it is certainly in decompensated cirrhosis. Effects of COVID-19 patients in patients with decompensated cirrhosis. ACLF can be precipitated by COVID-19. Seen several cases. I'm sure my colleagues across the country may have as well. Consider evaluating patients with liver disease for COVID-19 if they develop new onset encephalopathy or other acute decompensation. Consider liver transplant evaluation only for patients with severe disease and high MELD score were likely to benefit from immediate liver transplant. Now, what about the cirrhotic patients who get it? This is an international registry of these patients, and every p-value when it comes to, in fact, child score A, B, and C, as we get worse, the p-values get more and more significant for more and more deterioration. The outcome in patients with non-cirrhotic chronic liver disease or cirrhosis with COVID-19, as we see, this is the case fatality rate, and this is decompensation, CLD. In fact, you can see the case fatality rate under 20%. It goes higher and higher as we go into CP class C, almost like 60–70%. What about the decompensation? Same phenomena. Patients who are not the child's A, B, and C, they get worse and worse with the infection of COVID-19. Liver transplant recipient infections, the data reported from last year was rare for all these three viruses, MERS, SARS, and COVID-19. The Italian cases, initially, they reported deaths in few cases of liver transplant. Post-liver transplant patients are greater risk for COVID-19. There is a question mark. Profile of COVID-19 positive may be no worse in liver transplant patients than non-transplant. We are already on immunosuppressive therapy, as you know. In fact, we are giving more and more steroids to these patients as standard of care in COVID-19. Anyway, they may be at lower risk of hyperinflammation and cytokine storm and severe lung injury. These are this data cannot be taken as 100%. There is so much, in fact, is happening across the globe with these liver transplant patients and other transplant patients with COVID-19. High mortality in liver transplant recipients reported in patients on low immunosuppression with metabolic comorbidity. So it's not just the transplant, it's how these patients are after the transplant and what other comorbidities they may have. Post-liver transplant, immunosuppression may prolong viral shedding in post-transplant patients. Reducing the dose or stopping immunosuppression may precipitate acute rejection. And we all know about it and are very cautious when we are, in fact, looking into this aspect. Without COVID-19, do not reduce immunosuppression. COVID-19 positive liver transplant patients reduce high-dose prednisone but maintain sufficient to avoid adrenal insufficiency. Consider reducing MFF and CNI dosages, especially in the setting of lymphopenia, fever, or worsening pneumonia. What about the autoimmune liver diseases and immune suppression? In general, immunosuppressed patients considered at higher risk for severe illness for COVID-19. Immunosuppression may prolong viral shedding. Reducing the dosage or stopping immunosuppression may cause a flare in patients with autoimmune hepatitis. So we should continue with the same dose without COVID-19. With COVID-19, we may continue, as I've already said. Initiate immunosuppressive therapy in patients with liver disease with or without COVID-19 who have strong indication for treatment. Autoimmune hepatitis, graft rejection. In patients with COVID-19, use caution in initiating immunosuppressive treatment where benefit might be outweighed by risk. Cholestatic liver disease. Whether SARS-CoV-19 infection exacerbates cholestasis in PBC and PSC as multiplies in cholangiocyte. We know that, in fact, there are receptors available everywhere in cholangiocytes. Are they more susceptible? So we agreed that we must continue with the ursodeoxycholic acid. However, new investigational drugs should be looked at with skeptics. This is the COV life cycle and drug targets. And all these drugs, have been used, are being used for management of COVID-19 patients. And do not forget that they have drug-drug interactions and several drug-related side effects. So DILI certainly must be a serious entity in treating COVID-19 patients, and the treating physician has to be cognizant of this fact that no harm should come, or minimally, he should actually select those medicines to produce less harm for the liver. How would COVID-19 change hepatology practice? It has affected hepatology practice, of course, and we are learning through the teleconsult, and certainly it has made a super cause for our patients who were otherwise completely in disarray what to do. So ladies and gentlemen, from whatever I've discussed, COVID-19 has got implications on a normal as well as diseased liver. Chronic HBV, NAFL, cirrhosis, possible risk factors for severe COVID-19 with bad outcome. Stable hepatitis, chronic hepatitis C patients, have they got increased risk? We don't know. I haven't seen many of these patients going into any problems, and the world data correlates with that. So I put a question mark there. Patients with liver cirrhosis, liver cancer, or immunosuppressant with autoimmune hepatitis or post-liver transplant might be more susceptible to COVID-19 because of their systemic immunocompromised status and other comorbidities. Severity, mortality, and incidence of complications in various liver disorders, HBV, HCV, alcohol-induced liver disease, cirrhosis, HCC, post-liver transplant patients need to be examined in large cohort clinical studies. Data has started to pour in now. How different underlying liver etiologies, stages influence liver injury in patients infected with COVID-19 needs further study. Remember toxicity and interactions of investigational COVID-19 drugs. Thank you very much for, again, giving me this opportunity to relate to this talk. Thank you.
Thank you very much, Professor Wasim Jafri, for your time. I would request you to stay with us till the end of this session so we can have a question-answer session by the end of this